our next speaker, and moderator for our meeting. Now, you have in your packet a summary of all of us who are speaking today, and you can look at that in more detail about who Jan is, but I'm not going to read that to you because I know Jan. I've known Jan for a number of years, and Jan is one of the heroes of our prostate cancer cause. Jan is a good reflection of the fact that prostate cancer doesn't just affect men who have the disease, it affects, maybe it infects too, it affects so many of our families, so much of the fabric of our society, and part of us telling our story is to identify people like Jan. Jan is a role model who's speaking up, who's come here today to take an active part in this. Jan works for the Prostate Cancer Research Institute based in Southern California. They are having their annual conference soon in LA in early September, and there's information available for you. I've attended that meeting. Many of you in this room have. It's it's probably the best gathering of patient conference event speakers in the country. And please, if you have the wherewithal to make it there, please put it on your schedule. Now, Jan has lost her husband to prostate cancer. Jan learned so much of what she learned along the way helping Dominic stay alive. I've met Jan's son as well. So I'm pleased to be able to introduce you today. You are a warrior, and I am honored to call you my friend, Jan. So please welcome Jan Manarite.
Good morning. I don't know if you can read that, but it says 7,096.0. That was my husband's PSA at diagnosis. Okay? But the first thing I want to tell you is that he lived after that for 13 years. That's why I'm here today. Okay? Somehow, I learned some things along the way that helped us out immensely. And every time I did, I felt like I was finding a little gold piece in a pile of sand, or, a gift, or a flower in a dead field. And I felt like I was gathering these things along our journey. So that turned into, like this happens so much in advocacy, people come from crisis and brokenness and tragedy. And I have a feeling that each one of you has done this also in your own way. But then you find a way to share what you've learned with others. So I'd like to try to help you today with some of the things that we learned. I want to share those and see if they help you. And my hope is that it also helps you today with your questions and answers, because we are definitely making time for Q&A. Okay, this is your meeting. All right? I know our logos are up there, but this is your meeting. So we want to be able to meet you where you're at and help you get some answers that you can carry forward, let's say, to your next doctor's appointment. That's a good target. I'm going to play with the word target today. So where do I start after a PSA of 7,096? My husband, just so you know, was a stubborn man. You may have figured that out already. So that's why the PSA was so high. It's not that the medical system failed us, although I'm going to be honest, I ran into a lot of challenges and flat out frustration with the medical system. But my job as his advocate was to keep him as the focus, not my frustrations, and not the physician or not the receptionist. And that's what I had to digest and process and learn. So that's what I'm going to talk about today. Believe it or not, you need to go backwards sometimes before you go forward. So trying to research prostate cancer on the internet, which is overwhelming sometimes, it's certainly vast, it's endless. Instead of going backwards first, to pull up some of your medical records and identify some keywords that tell you what your prostate cancer is. Then, when you go to the internet, now you're researching prostate cancer, Gleason 3+4, clinical stage T2A, because you now understand that that's what you have. Okay, so I'm going to help you with that, because it is overwhelming. Everyone in this room who has prostate cancer has a different prostate cancer than the person sitting next to you. We all are starting to get that, right? We all realize? So that's why it's important to understand some key points. And let's think in terms of bullet points, okay? Not paragraphs, because again, that's overwhelming. But I'm going to try to help take you there. And I'm giving you a checklist here of medical records that you really should have your own copy of. All right? Pathology is anytime tissue is removed from the body, there's a pathology report somewhere. That tissue is sent to a doctor called a pathologist. So you will have a pathology report from biopsy every time you've had one, whether it's negative or positive. Okay, and does everybody have the handout? There's a handout with copies of the slides. It's in your blue bag. Let me hold one up. Hold on. I want you to be able to take notes. So the slides are right on here, and you can take notes right on the slides. Write down thoughts as you think of them. If you have a question, by the way, write it down. We're going to get to Q&A later. It's possible that your question will be answered as I continue to speak, and if not, we'll come back to it. Okay? So, pathology report. And I'm going to argue that this is your most important medical record because it's the only thing that can truly diagnose your prostate cancer, number one. Imaging cannot diagnose. Okay? PSA does not diagnose. PSA and imaging point to the probable need for a biopsy and the probable existence of prostate cancer. But only pathology can diagnose, and that's why it is so important. Okay? So, pathology report or reports, plural, first of all. You also have a pathology report from your surgery if you had radical prostatectomy. All right? So make sure you have copies of those. Now, we're in a world where medical records are becoming online a lot, so your physician's offices may have access to medical records online, which honestly I find is a lot easier because I can go and search anytime I want to. So make sure you ask the this is a great question for the receptionist, not the doctor. Do you have this set up online? How do I get connected? Because they'll have to give you a username and a password. It's free, but you need to sign up and create your own identity. Okay? So either you have the medical records in hard copy, or you have access online, or maybe you have a little bit of both. So other copies of medical records, obviously blood work, PSAs. For anyone who has prostate cancer, PSAs are important. I want to make this statement because I'm not sure this is explained well. Does everyone understand? Everyone's familiar with the PSA controversy, right? We remember the task force and we all scratched our heads, and I want you to know that almost no one agreed with the task force when the recommendation came out. And I'm talking about the urologist, which is AUA, the oncologist, which is ASCO, the radiation oncologist, which is ASTRO. The only organization that I found initially that agreed with them was, I'm going from memory here, so forgive me if I get this wrong, but I'm pretty sure it was the American College of Family Physicians. Everyone else had a different interpretation. So I just want you to know that. The reason I'm saying this is because there was a period of public comment with the task force recommendation. So the public commented, but they didn't make the comments public. So people couldn't see the comments coming in from professional organizations. Okay, so my point here, though, is that with the PSA controversy, the entire thing was only about screening. It was only for men who don't have prostate cancer. There is no task force controversy about your PSA if you have prostate cancer. Everyone get that? I'm not sure that gets explained. So if you have prostate cancer and you're monitoring your PSA, the task force was not talking about you. Your PSA is valuable, it's important. I would argue that the more you understand it, the better place you're going to be. And we'll talk about that a little bit more, hopefully, as we go on. But I do not believe the goal is to throw out the PSA. It never was. I also don't believe that the PSA was intended to be perfect, because nothing in science is perfect. I do believe it's intended to be understood. So the funny thing is, for me, with my husband, the more PSAs I took, the more I began to understand, because I wouldn't hang my hat on one PSA every 4 months. So I could look at a pattern, I could think about it, I could digest it a little, and I didn't have a major reaction which sent me into tears in the next doctor's appointment. But it allowed me to see more of a panoramic view of what the PSA was doing in context of the treatments he was starting or stopping, in context of his imaging, which would be bone scan, CAT scan, whatever, in context of how he felt, and so on. That, for me, worked. So I'm just sharing with you. There's one of my gold coins. That worked. Another copy that you should have is dictated written reports from any of your imaging. Okay? Now, I'll often suggest I'll ask someone if they have a copy of their CAT scan. They say, oh, yeah, I have a CD, and I've got it with me. But the CD is usually the actual imaging, which only a radiologist or nuclear medicine physician can read. Often, the urologist can't read it because that's how he was trained. He's trained as a surgeon and some other things, so he relies on the radiologist to interpret it for him. However, that radiologist will issue a dictated written report for the urologist and for you. So for any imaging you have, there's a dictated written report somewhere, and I think you should have your own copy. Okay? So I listed some imagings there that are most common. CT scans, obviously, we do a lot of those in prostate cancer. Bone scans, by the way, there are 2 different types of bone scans, and we're going to talk about that later with Dr. Graham. So you may have a technetium-99, a T99, that's the most common one. But there's also this PET scan called an F18 or a sodium fluoride. It's a different type of bone scan. So I'm just letting you know there are 2 different kinds. Okay? Now, when you go back and look at your bone scan report, hopefully this allows you to look and see what kind you have, or what kind you've had. Okay? Ultrasound. This is one that gets overlooked in my experience a lot. And the reason this is important is when a biopsy is done, the urologist uses an ultrasound to direct the needles. Okay? And with that ultrasound, it's a type of imaging. So there's a dictated report somewhere that says sonogram, ultrasound, and on that report, one of the pieces of information that is important, especially if you're newly diagnosed, is the actual size of your prostate. Or they'll call it volume, the volume of your prostate. That's an important piece of information. It may even bear on your treatment decision. I've had callers who had a 17-gram prostate, and I've had callers who had a 200-gram prostate. You think their treatment decision might be different? Right. So it's a key piece of your information that is helpful. And it's usually measured in either grams or cc. So understanding the size of your prostate tells you, if you're screening, how much PSA you should probably be making, because a larger prostate will make more PSA than a smaller prostate. It may bear on your treatment decision. Again, some men who have very bad urinary symptoms, radiation is likely to exacerbate those, and surgery is actually possible to relieve them. That may be just part of the factoring in. That's not a decision maker all by itself, but that may be something you factor into your treatment decision. So size of prostate from ultrasound from biopsy is a piece of your medical records that you need to have a copy of. So MRI, prostate MRI is something that is being done more and more, and we're getting closer and closer to having the kind of research that secures the data for the doctors and for FDA and Medicare, and hopefully that'll happen in 2015. And you can write this word down if you want. It's called PIRADS, so it's capital P-I hyphen R-A-D-S, PIRADS. And if that sounds like BIRADS, that's because breast cancer has BIRADS currently. And it's a standardized way that allows the medical system and all your medical professionals to work for you and deliver to you what you need. And it also helps with insurance reimbursement. And it's all based on years and years of clinical trials. So they're gathering data for you. So we have BIRADS in breast cancer. We're hoping to have PIRADS in the United States in 2015. I know that they have them in Europe, and I understand that the data has been compiled, and we're probably waiting for all the groups to come together and agree. So PI-RADS and MRI are coming soon. Okay, well, here's how I felt about my medical records. I don't know about you, but that's exactly how I felt. It was just absolutely overwhelming. I looked at them and I thought, what am I doing with this? But somewhere in my instincts, I knew that if I understood a few key issues people were measuring my husband, they were imaging him, they were looking at his cancer. There were things in there that I needed to have, again, bullet point understanding of. So what I learned to do was start researching some of the words. I was shocked. Every time I picked up a big word, ran it through Google, it came up with a very simple explanation, to which I thought, well, gee, why didn't they say that? But this is what happens. Science has words that are different that we're not familiar with to say simple things that we do understand. So I really want to encourage you to take that medical record, and you may feel like you want to put your head down on your computer, but to pull out a couple of words and research them and see if that doesn't turn on a light bulb for you. I'm going to give you a couple of examples. If you don't use the internet, that does make it challenging. I'll be honest, it's much easier with the internet. But you could try one of your medical professionals that has a little time to spend with you. We all know that our doctors have a tendency to be crunched for time, and I'm going to tell you it's not their fault. Okay, the medical system is pressuring doctors. But sometimes you can find a nurse who does have the time, or another medical professional. And the last thing is, honestly, this is what we help with on Helpline all day long. PCRI has a helpline. I think it's probably a little bit different than Tom Kirk's Us Too helpline. I think that organizations tend to look like their leadership looks. So Tom is a social worker, and they have a great talent, and you help me if I'm wrong here, in understanding the whole psychosocial and the connection support thing, whereas our executive director is an oncologist. He's an MD. So we tend to get into the details of the cancer itself and try to clarify things for you. I feel like I spend my life taking complex concepts and trying to put them into plain English. And that's what's so important with medical records. So I'm actually going to show you a couple of examples. Here's some words that you probably have seen. From your pathology report, we all saw adenocarcinoma, right? We wonder, what the heck was that? Well, it's just cancer. That's all it means. Simple terms. It's your prostate cancer. I'm not going to go into detailed definition. You can look it up. But in terms of what you need to know, it means your cancer. Some other terms we see on a pathology report or on imaging report, simple terms, apex and base. Well, they're talking about the prostate, which you might say, and Dr. Odo is probably going to go into this in greater detail later, but you might say is a little bit like an upside down triangle. Therefore, the base is actually the top of the prostate. Sounds backwards. And that's where the seminal vesicles are. And the apex is the bottom. All right? That might be important, and it could even play into a treatment decision. Again, there's issues with the apex that are unique, different from the base, having to do with it's not quite as well defined, the connective tissue isn't just as clear, and it's even a little bit easier. There's some literature that's easier for the cancer to escape in the apex area, and somebody can correct me if I'm wrong on that, but they're just, my point is they're important words, and understanding the word may help you in understanding your cancer. So a couple other quick ones. How many here have had a CT scan? Have you seen that word on there, lymphadenopathy or adenopathy of the yada, yada, yada? All that adenopathy means enlarged, too big. And I'm looking to Dr. Dillahay and Odo here to correct me if I'm wrong on anything. But I'm trying to come up with that simple explanation for the cancer patient. So lymphadenopathy means that your lymph nodes are enlarged, therefore they're probably cancerous. That's what they're looking for. I'm going to do a quick little bullet point here about imaging and how nothing in science is perfect, okay? No scientific results come out 100%. Nothing is absolute. So with imaging and with PSA and everything else in medicine, there's degrees of accuracy, or there's strengths and weaknesses depending on what you're looking for and in which part of the body, especially with imaging. For the CT scan, the ability to actually see cancer cells is not there. That's not what the CT scan does. What the CT scan does is, in simple terms, look at anatomy. Okay, it's very good at seeing anatomy. Again, I'm looking at Dr. Dillahay, and he seems fine with everything I'm saying so far. So therefore, what they're doing is they're looking at your lymph nodes and they're measuring them because they're looking at anatomy. And if they're too big, then they're probably cancerous. Okay? Did everyone realize that? Does that help a little bit? Perfect. That's my goal. Okay. So moving on to bone scan. Some simple terms you'll see. Sometimes they'll talk about the arm or the leg, and they'll say proximal and distal. It's just a word for proximal means, like if you're talking about the arm, this would be the proximal arm, this would be the distal arm. Just proximal is closer to the torso, distal is further away. Again, I'm just trying to give you some simple explanations for words you see and you think, what the heck is that? So, osseous is a word that's used on bone scan a lot. It just means of the bone, like osteoporosis, okay? Osseous, of the bone. But again, you can see how if you would take these words and just Google them quickly, you'll find a definition that is simple, plain English that will help you understand your personal cancer, because your personal cancer is different than the guy sitting next to you. Therefore, what is yours? Right? That's a key question. The more you understand that, the better your internet research will be, and the better your questions will be for your doctor. And the better question you ask, the better answers you get. And that's the path. Okay? And that, for me, felt empowering. I went from overwhelmed to empowered. And little pieces at a time, because nothing's perfect. But this is what gave me clarity. So this is what we teach on PCRI Helpline and at PCRI. So when you have a question for the physician, and we're going to do some questions today, right? I want you, after Dr. Odo talks, I'll even try to do some myself with Q&A. This helped me too, because again, it was overwhelming. It's not too many cancers, I don't think, where number one, you're told you have cancer. Number two, you're told to make your treatment decision, right? So it is overwhelming. When you go into your doctor's appointment, remember there will be more doctor's appointments coming up, so pick your battles. What's most important for this appointment? Pick 5 questions and let the others set. You can come back to them next time. Or think about which ones can I ask the nurse and she can call me back, or which ones can I ask the pharmacist even, and I'm going to get to that too. Please research your question before you ask it. If you see something on TV and you log it in your memory and then you try to carry it to a doctor appointment with no research, it's going to be really hard. You're not going to, I saw something on TV, I don't remember what it was, you can't even have the conversation. So if you see something on TV, write it down, then go to the internet research and find out what it really was, and then bring that question to your doctor. And there's my, keep the patient first. That was my statement about, I found that I was often overwhelmed and frustrated, and my goal wasn't to argue with the doctor. Once I found myself in that place, I'm in the wrong place. My goal was to advocate for my husband, always. And I knew that, but when you're overwhelmed, sometimes it gets a little overwhelming. Think about just keeping the patient first. Sometimes I would defer to my husband as I was asking my questions. I had to realize what were my questions, what were his, right? It's his cancer. I'm just the helper. So I would often start the question, then I would defer to him so he could say, so the conversation then became between the doctor and my husband, not me and the doctor with my husband sitting there. So and I always had to think about what he really wanted, what was important to him. It was his cancer. Ultimately, everything was his decision. I was just a helper. So keep the patient first. And there's my quick comment about nothing's absolute in science, nothing's perfect in medicine. I know we want it to be, but I don't think that's a scientific statement. So I'm going to give you a quick definition of some terms that are used a lot in science, and they're used definitely in imaging. They're used in MRI, they're used in PET scans, bone scans. They're even used for PSA blood tests. Sensitivity and specificity. Here's my simple explanation, layman's term. Sensitivity means that, okay, let's say they take a bone scan. Sensitivity means that, okay, they're looking for cancer. It means if you had cancer in the bone, it would show a mark on the film. Okay? Dark spot, white spot, whatever. Specificity means that if you had cancer and they're looking for it, what they saw in the film really was the cancer and not something else. Does that make sense? Am I clicking yet? So it's kind of like sensitivity is the ability to not have a false negative. Because nothing's perfect, right? So there are false negatives. There are false positives, which, by the way, is a great question to ask the doctor when you have some imaging to get an understanding of what's really going on with you. What is the accuracy of this imaging? What's the degree of false negatives and positives? And just have an honest conversation about that. Take a couple notes, and then go home and think that over. Right? Making sense? So I'm going to defer quickly to Dr. Dillahay. You okay with my definitions here? It's all right? Okay. I just have to make sure. I'm coming up with my personal layman terms for some big concepts. So, all right, so moving along, here's one that helped me a lot. Boiling it down. Every treatment I thought about, I thought, okay, well, what's the pros and the cons? But if you turn it into risk versus benefit, now you're using language that you understand, and so does the physician, because this is a very scientific dialogue, risk versus benefit, all day long. So take your questions into a risk versus benefit developed question and understanding, and have that kind of a conversation with your doctor. Are you thinking about a treatment and you don't know whether to try it or not? Start writing down risk and benefit. Risk is basically side effects. All right? Let's talk about that for a minute. I'm going to hit those TV commercials that go, side effects include diarrhea, death, and loss of everything that you known to you. Okay. Serious side effects are rare. They're almost always rare. Okay? They don't say that, though, because they don't give you the percentages of those side effects when they mention them on television. And I'm going to go even further. I worked with, actually, Dendrian on this a little bit, who makes Provenge. And the next brochure they came out with later was they started listing percentages. It clarifies a lot. If the serious side effects were not rare, this risk-benefit profile would have never worked with the FDA, and it would have never got FDA approved, okay? So when you hear about these serious side effects that scare the bejeebers out of you, ask your physician or go online and look for the percentages. So if it was a 10% of people had this serious side effect, that means that 90% did not. What actually happens eventually is you start to realize that this 10%, the small group, they had something in common. Those were actually risk factors for that side effect. All right? If you don't have any of those risk factors, it's negligible for you. Is this making sense? Okay. So I'm just trying to break it down a little. But use this slide even today while we're talking about, and you're thinking, when Dr. Odo's talking, for example, about MRI, and you're thinking about a question, think in terms of risk versus benefit. Take some notes. You can write on the back of your sheet. And it just creates better questions for your doctor, which gives you better answers. Target who you ask. There's some questions, really all medical questions you need to run through your physician, but he's also more prone to, let's go back, he's more prone to do the benefit column, okay? That's his job, is to eradicate your cancer, attempt cure, whatever, that's his job. However, the risk column, which is side effects, I have found personally is often a better question for the nurse. She just seems to have more time, and she seems to have more patient touch and conversation, and she often has a better understanding. So I began targeting questions about side effects to the nurse. Questions about prescription drugs. I learned eventually to start asking the pharmacist. I ask the physician, but I also go to the pharmacist because they have a deeper understanding about drug interactions, contraindications, the drug itself. Plus, they had a whole lot of time for me. Some of them are available 24/7, right? On the telephone. So, and this I'm going to go through briefly because we're getting a little close on time, but you've got this in writing now, and I want you to be able to refer back to this. I find that my callers don't understand the difference between a radiologist and a radiation oncologist at all. and therefore they don't know who to ask their question to. So these are the three main doctors we use in prostate cancer, right? The urologist, the radiation oncologist, and usually later, for metastatic or more advanced disease, the medical oncologist. But I would argue that there may be a choice in there. Maybe you want to ask to consult with a medical oncologist. Understanding these bullet points, and for people who came in late, all the slides are in this handout. I don't know if you guys have these. It's inside your bag. So this list might help you look at and decide, well, I do want to make an appointment with a medical oncologist because I want to be consulting with an internist and a hematologist. I don't know. That's your choice. But you can see how the differences, what they are. So I also listed here some of our speakers. So Dr. Catalone is speaking after Dr. Otto this morning. He is a urologist. We do not have a medical oncologist speaking today. But Dr. Tomlin, who's speaking this afternoon, is a radiation oncologist. All right? Now, some of these bullet points can vary in different situations. For example, I know that some radiation oncologists who are involved heavily in clinical trials do prescriptions and blood work and some additional things that sometimes in the community doctors' offices they don't. Okay? Here's another group of doctors. Pathologist, that's the guy who you never, these are non-clinicians, okay? These are the physicians that are really important in your care and you never meet them. All right? The pathologist read your tissue and gave you your diagnosis. He's very important. All right? He's a separate physician. I'm just letting you know there's separate physicians. They can also read and interpret blood work. So I should have added that bullet point, and I'm sure there's a couple other things that I'm not aware of. Radiologist, here's the radiation oncologist. He treats with radiation. See the middle column? Here's the radiologist. He reads and interprets your imaging. They're two different doctors. There are some interventional radiologists that do actually treat patients and do a little bit of clinic work, but many do not. And I think that may be shifting. Am I right about that, Dr. Otto? Yeah. So there may be a shift happening in that, where they go from somebody you never see to somebody that you do consult with once in a while. Because science is always a moving train, so is prostate cancer. Things are shifting and moving, and we're always trying to keep up with it. A nuclear medicine physician does the same thing as a urologist. He reads and interprets imaging, but he has, the Society of Nuclear Medicine. Does anybody know what nuclear medicine is? Because what the heck is nuclear medicine, right? A quick explanation. Nuclear, and tell me if I'm wrong, nuclear medicine is anything that uses a radioactive pharmaceutical, a radioactive injection. In imaging, radiology tends to be good at seeing anatomy. I'm generalizing a little bit. Nuclear medicine will have an injection that's intended to go into your body and seek and try to find the cancer cells and light up on imaging. That's the difference. CT scan sees anatomy, we just talked about that, right? Nuclear medicine imaging, like a bone scan, has an injection. How many people have had a bone scan? So you went in, you got an injection first, right? You came back 3 hours later, and that injection was intended to go in and seek and try to find your cancer cells and produce a mark on the imaging. Now remember, nothing's perfect. They all have sensitivity and specificity. They all have false negatives and false positives. But that's the difference between a bone scan and a CT scan. A bone scan is nuclear medicine. A CT scan is radiology. Okay? So nuclear medicine physicians, and this is another shift, will also administer, there are treatments that are injections that are radioactive that are intended to go in and seek out your cancer, not image them, but treat the cancer. Okay, and that's going to be one of the things we talk about today, which is radium-223 or Xofigo. People heard of Xofigo? Okay, that's Dr. Tomlin's talk this afternoon, radium-223. Every drug has two names, by the way, if you haven't caught that yet. So Xofigo and radium-223 are the two names for that drug, or for that injection. So I wanted to show you that Dr. Otto was a radiologist, and Dr. Graham, who's speaking about PET scans this afternoon, is a nuclear medicine physician. Any comments on my doing okay? All right, I'm checking in. Now, other medical professionals. Now, I'm going to be honest, a naturopathic doctor is something I'm learning about. This is not something we had in Florida, so this is new to me. But I know that when it comes to not trying to cure cancer, but when it comes to dealing with the side effects, there's a lot of naturopathic or naturopathic approaches that can be really helpful. Whether it's supplements or, honestly, I've seen some really interesting literature about acupuncture for things like hot flashes, even depression, fatigue, nausea. So the naturopathic arm fills in kind of well, for me it's a new space because we haven't really had this where I was at. But Dr. Tracy Thomas this afternoon is talking about ideas for treating side effects from hormone therapy. Obviously the nurse, I'm going to start going a little faster here, you guys, if that's okay. And I want to mention the pharmacist again because I often refer to them as the forgotten medical professional. They have time to spend with you, bringing your list of drugs. You know, they understand the medications. Have a conversation with your pharmacist if you have questions about drug interactions and medications. I'm going to give you an example. There are some times when your drugs that you're taking will interact, and it can be bad. One can make the other stronger, one can make the other weaker. So I've seen cases, sometimes it can be your blood pressure medication, let's say, okay? I've seen cases where people found out there was an interaction, they stopped their blood pressure medication, or they were taking another pill that increased their blood pressure medication, they weren't monitoring their blood pressure, and they ended up in trouble. So there's ways to do that where it works for you medically better. Sometimes you can just take them 2 hours apart. So that's the question to ask the pharmacist. Instead of stopping one cold turkey, sometimes you can take them 2 or 3 hours apart and still stay on your medications. So again, it's finding the right question. Quickly, do you ever wonder why your doctors tell you different things? Why doctors disagree? Why did one doctor say one thing and one say the other? In science, this evidence, or let's say the research, the statistics that they have, there's different levels. Everybody wants level 1, but everybody doesn't get it. It takes a lot of years and a lot of work to come up with the clinical trials that produce enough statistics to give your doctor level 1 evidence, because that's really what he wants, but he doesn't always get it, okay? Sometimes he's down in level 2 a lot, which means we're working off of research, but it's not as definitive as we'd like it to be. But the truth is, we often are intrigued with level 3, which might be a book written by a doctor, but that's different than level 1. So again, I've given you these slides, you can take them home and look them over, but I hope this gives a little quick understanding why doctors might disagree. And it's helpful to understand where the physician's coming from so that you can keep focused on the patient and keep them as the most important thing. I think I covered all this. This is about today, taking notes, and I do have this video, but I think we're short on time, so I'm not going to play it. I want to ask you guys if you have some questions. That's where I'm at. And I think I've got some microphones. I need 2 volunteers. Maybe 1, 2. This is Morgan. She's done all of our AV today. She's helping out Sima from the Society of Nuclear Medicine and Molecular Imaging. What I'd like you to do is yeah, this is fine, but she's going to come to you with the microphone, so just raise your hand and we'll get to you. We're probably going to run a little over, but... My lapel mic. Okay.
Thanks for your presentation, Jan.
Yeah.
Question about Dominic, how long ago he was deceased and whether or not he had the opportunity for a lot of the drugs that came on the marketplace in the last couple of years?
Yeah, he was diagnosed in 2000. So he lived for
2013.
Yeah, so we did this journey, and the last few years were tough. I'm going to let you know, it wasn't easy. For 13 years. But I know that he'd be proud of me doing this today, so that's why I do it. As far as the newer drugs, we did most of this work for him before Provenge, Zytiga, Xtandi, Xofigo, et cetera. 2010 was Provenge, and then I think 2011 was Zytiga, and so a little bit of both. But I was doing a lot of, I refer to common sense as correlation and correlation as two of your mindsets that are really scientific and really help you with cancer. And that's what we were doing for 10 years.
Quick comment on your first slide about medical records.
Sure.
The other thing you can ask for is doctor's notes, particularly
Okay.
when doctors refer you to another doctor. They write notes to each other about what your case was.
Very good. Did everybody hear that? One more thing on the checklist for medical records is doctor's notes or physician's letters, because they'll summarize, and they're really valuable, and they're really helpful.
And then
So-
at the meeting with the doctor themselves, you can get a USB device that doubles as a recording device for like $20 on pulsetv.com.
Okay.
Saves a lot of effort as far as scribbling notes that you can't read later, and you can
Okay.
re-listen to it and that sort of thing.
Yeah,
There's
different-
some one-way and two-way states as far as notifying the doctor that you're recording and so forth, but
Yeah. Perfect. Yeah, because some people aren't even good at taking notes. Or what, everybody's different. So find a tool that works for you. My husband used to say you need the right tool for the right job. And so that works here. And he built a motorcycle while he was sick. So I'm just saying the guy knew about tools. So yeah, if the recording works better than taking notes, absolutely, of course. And bring somebody with you. Two people hear two different things. Go ahead. Yeah.
So you had mentioned in your presentation here that medical oncologists are involved with treatment of prostate cancer. Everything that I've been exposed to, I had surgery. I'm now in recurrence. I haven't found a medical oncologist that deals with it. The radiation oncologist seems to take over that function.
Right.
And I'm wondering how common that is, and
Yeah.
and how prevalent medical oncologists are in this
I
field.
think it can vary, but I'm going to make the argument that you have the right to ask the question. Keep looking at those questions that you have the right to ask. Are you at a place where, looking at this list, you feel like you'd like to just consult with a medical oncologist? Then ask.
I haven't been able to find any.
if you're willing to travel, Schultz and Lamb out in Marina Del Rey, California are always available.
Do you live in the Chicago area?
Northwestern, University of Chicago, they both
I don't know what you
handle
mean by you haven't found any. Have you looked online?
Yes. I mean,
So I'm going to give you a name that you could call. It may or may not be appropriate, but I know that Dan Chevron works with us too a lot, and Shevrin, and he's very familiar with prostate cancer. Dan Chevron. He's outside Chicago.
Who's
Yes,
the-
Dr. Odo.
University of Chicago, we also have a very active medical oncology program for prostate cancer. There are two dedicated, very experienced medical oncologists.
where is this?
University of Chicago. I think his question, though, is like, when will they see me, and when do I go, and that's hard.
See
Yeah.
prostate cancer patients all the time. That's what they do.
Well, not in the early stages, though, sometimes. They don't.
I mean, at his stage.
In recurrence?
Stage,
Okay. Dr. Dillahay.
No, it's just very different in every institution.
Yes.
There are people who, Dr. Catalona is going to speak later on as a urologist. Dr. Quizell, who's an oncologist here at Northwestern, also sees, that's his specialty, is prostate carcinoma. I know a lot of our radiation oncology people, once they've had an interaction with the patient, having treated them at one point, they will take over their care, I know frequently. It just depends on what their expertise is, what their interest is, what their level sometimes doctors get rather territorial too, and so once they get you as a patient, they don't necessarily want to give you back to the other doctor or whatever. I'm not getting into that.
They do.
But I think that some of them have more, there are some radiation oncologists who have an interest in monitoring and taking care of their prostate cancer patients beyond their initial treatment regimen, and they will do that, but it just depends on how your medical center is set up or who you saw in the first place.
So focus on the question that you want to ask. Take these notes home, look at the list, and if you really believe that you want to see a medical oncologist, you have the right to ask that question. And if it's not within your network that you're at right now, maybe you want to try somewhere else and Dr. Chevron's outside. I don't know. It's your right to ask the question and to come up with the right answer that works for you because it's your cancer. You're welcome. I'm sorry.
Oh,
Okay, go ahead.
Can you hear me? All right.
Yes.
Thanks, Jan, for
Yeah,
taking my
you're
question. I had varying PSA results, and I talked to my urologist, and he basically admitted that there's two kinds of PSA.
Mic up a little closer.
Two kinds of PSA tests. How important is it to have it all done at the same lab? And he said, actually, that's pretty important.
Okay, so real quickly, you're newly diagnosed, correct?
Correct.
So you need to know what your PSA means to you right now. So you're looking at your previous PSAs or just your current?
I had tests done at different labs. And
Different
I was
lab
getting different
PSAs,
numbers,
got it. Okay,
and-
there can
and
be a difference in the PSA result from different labs. It's usually minimal. It's usually not a lot. But if you're in a place where that number really means something in your care, you have your most important PSA right now, by the way, as newly diagnosed,
Yes.
is the PSA just before your biopsy.
Right.
Did you know that? That's called your baseline PSA. They're going to use that for your risk category, whether you're very low risk, intermediate, or high risk.
Right.
So you already have your PSA before biopsy. When they do vary between labs, it's usually not that much. So I would look at to try to rely on that PSA just before biopsy right now. But going forward, make an effort to just use the same lab. Is that possible?
Yes.
Does that answer your question then?
Yeah, that was
Okay.
basically his suggestion, yes.
Perfect.
Yeah.
Okay.
The other things that can affect it, like sex within 48 hours.
Right.
Sure.
Writing and that kind of stuff.
Sure. Yeah. Okay. Yes.
Yes, thank you. Just to follow up on something this gentleman over here said about oncology,
Yes.
and also one of your slides, a separate subject. I'm not familiar with Chicago. I drove up here from Cincinnati. But in Cincinnati, in the entire population of urologists in greater Cincinnati, which includes northern Kentucky, there are 2 urologists who are also oncologists.
Okay, I got to comment on that right away. It's still different. They're still urologists. They're surgeons.
Yes.
They're urologists who are oncologists, but I don't think they're medical oncologists. They may have, it's different, just so you know, because that's what I thought too, and it's different.
All I know is that there are 2 that are board-certified urologists and board-certified oncologists.
Which means they probably did a residency in medical oncology as well. So just
Ask.
that question.
Yeah, ask, because it can, what I found is it wasn't the same as a medical oncologist in my area. So again, we're focusing on those questions. Find the right question. I would definitely ask about that.
And on one of your slides about sensitivity and specificity,
Yes.
that's not incorrect, but just a more technical definition. Sensitivity is the probability of having the disease if your test is positive. So, for
Right.
example, a sensitivity of 80% means that if 100 people score positive on the test,
Right.
20 of those tests will be false positives.
Right.
Similarly, a specificity is the probability of not having the disease if the test is negative.
Does everyone have a little bit of, you got an understanding on sensitivity and specificity? Are you close? How many people have a little bit of understanding, you're kind of getting it? How many people don't get it at all? So these are terms used for medical tests, okay? Whether it's a blood test or imaging. And since nothing's perfect, your CAT scan isn't perfect, okay? CAT scan has actually a very low sensitivity and a high specificity for prostate cancer. So we're just trying to give you some term. It might take you a while you might even find your own words, but I don't know if I'm helping. Yes.
I just had a comment about access to our records, and I'm part of the North Shore Health System, and we've had online records for quite some time.
Okay.
But the adequacy of what's there and what we have access to seems to be rather limited. Usually, you wind up with codes that you do look on Google, tell you about the protocol and what was administered, but not about the results that the doctor saw or interpreted. The only thing I've ever seen any detail about has been the radiologist reports they
Right.
actually provide, and they're usually included. But I see the physicians inputting stuff in the office, and I know that's going into the online medical records. But as a patient, it's not up there, and I think if you have to make a special request, it usually becomes kind of a difficult process. This stuff about doctor's notes, I don't know exactly whether that's an easy process or not. I'd like to see some of those, but not sure how to do it.
So you may have to ask the question of your doctor about, I would print out the screen and bring it in, because I know that when I go into my medical records online, there's a bunch of stuff that doesn't even matter to me, but there's this one section that's my test results, and that's all I'm interested in. So the other sections, you might even be in there, they have ICD-9 codes, and they have diagnosis codes that to submit to insurance. Like prostate cancer is 185.0. I mean, I don't need to know that. So you might be in that section. So you just need the test results or whatever they call it, and ask your doctor, receptionist, and probably the nurse even, maybe, about how to make it work for you.
Okay.
I got a microphone in the back.
I want
Put
to
the microphone right close to your mouth. Yeah.
Okay.
Thanks.
I wanted to know when and why would someone need a CT scan for lymph nodes?
Great question. So let me ask you a couple questions. Is your husband, is he in a place where he's newly diagnosed, having recurrence?
Yes, no, just newly diagnosed.
So they would likely do it most commonly for suspicion of lymph node involvement. Okay? Make sense?
Well, that would only be the case he's had a biopsy and the doctor or the pathologist indicated that none of the lymph nodes were affected. Is
The biopsy, are you saying they sampled some lymph nodes? They pulled some out?
Yes.
Surgically, like a laparoscopic lymph node removal?
I don't know about that. I don't
think so.
No, they didn't.
Yeah.
This is just from the biopsy that the doctor had said none of the lymph nodes were cancerous.
Okay, so let's develop some questions for you, for your doctor, and for you to research. How do they know lymph nodes were or were not involved? I would start with that, because you don't know it from a prostate biopsy. So if that's what you think you heard, you might have heard something different. Making sense?
Yes.
Yeah, prostate biopsy is the prostate. They do not go in and sample lymph nodes during a prostate biopsy. So to say no lymph nodes were involved, there had to be a reason that he said it. I would ask him why he said that.
Okay.
Has your husband had a CT scan?
No.
No, okay. So if his PSA was was high and the Gleason was high, they might say, well, there's possibility of lymph node involvement, so we'll do a CAT scan, CT scan. But on the CT scan, what they do is they basically measure lymph nodes because it's good at seeing anatomy. So it's not the most accurate imaging, but it's what we use right now. I'm just giving you the truth. Does that answer your question?
Well, is there something in particular in the biopsy that would indicate that they should go further with this? Does it
It would
have
be the
anything to
Gleason.
do with the number?
It would be the Gleason. Do you have a copy of the pathology report yet?
3 plus 3.
Say it again.
3 plus 3.
I know I'm running over. I got to quit here pretty soon. Sorry, Dr. Odo. If the Gleason is 3 plus 3, that is the best Gleason you can have. That is the lowest number there is. There is no 2 and there is no 1. Okay? So start with that and research in that context and start developing your questions from that. So I'll give you that much information. Okay?
Thank
3
you.
plus 3 equals 6 is the lowest Gleason you can have and the best Gleason. That means it's the least aggressive type of cancer. Now, I don't know how much cancer they found. I don't know the rest of the information. But the Gleason measures aggressiveness. How aggressive or non-aggressive is it? All right, so I'm going to shift now and I pushed Dr. Odo back 20 minutes. I'm sorry. But I realized that I should do some of my own Q&A. I'm sorry.